This video is going to cover the knee and the tibia and fibula. So although the knee appears to be a relatively simple and straightforward joint, it actually has a lot of complexity, especially on imaging. So I'm sure many of you have had friends, family members, or even yourselves have experienced MCL, ACL, uh, menisci tears, etc. So there's a lot of uh, injuries that are common with the knee joint. And so we'll spend quite a bit of time looking at the structures of the knee on imaging because it's one of the primary ways that we diagnose the specific ailments of the knee. Obviously, there's a number of clinical tests that can be done to help sort of give us a strong differential diagnosis of what might be going on with the patient. But much of the time, definitive diagnosis relies upon imaging studies in order to develop or to come to a definitive diagnosis. So looking at some of the key structures here of the knee, you'll recall that in the proximal femur, we can see the lateral and medial epicondyles along with the femoral condyles, which you can see are covered with articular cartilage. Then we have the patella, which remember is just simply a large sesamoid bone. So we are not born with a patella. It develops over time as we are using our quadriceps in order to stand upright. Eventually that patella will form over time. Then looking at the tibia, remember that we have the tibial plateau, which is sort of the smoothened out area on top of the tibia, which is also going to be where we have our tibial condyles, which are also covered over by articular cartilage. And then looking more inferiorly, you can appreciate the tibial tuberosity, which forms an apophysis in a child. And then you can see in the fibula, we obviously have the head articulating with the tibia, and then also the neck, which is the weakest point of the tibia and is prone to fracture. And remember that your common peroneal or common fibular nerve is also located right about that region, and so with any fracture of the fibular neck, that's going to put that nerve at risk. Here we have a sagittal or a lateral view of the knee, and so you can see looking at laterally in, we have a good view here of the head and neck of the fibula. You can see the lateral condyles of both the tibia and the femur and the articular cartilage associated with each. You can also see a good view of the tibial tuberosity right here as well. And then finally the patella anterior to the femur. Now looking at two radiographic views of the knee, you can see on the left we have a lateral view and on the right we have an AP view. So looking at the lateral view first, we can appreciate the head and neck of the fibula. Here you can see the tibia, tibial plateau, along with the head of the lateral condyle of the femur, and then here we can see the patella located anteriorly. Looking at an AP view, you have to look relatively closely to be able to appreciate the patella through the femur, but you should be able to view the patella relatively easily on an AP view, but you do have to look closely to see it. And then you can see the medial and lateral, so this is lateral over here, lateral tibial condyles, which are also going to be covered by articular cartilage. And then you'll notice that you can see the joint space in between the tibia and the femur, and on a typical or a conventional radiographic view like this, you will not be able to appreciate any of the soft tissue structures, so you really need MRI in order to be able to do that. And here's your fibula finally over here. So remember that you should always use your fibula to help you orient yourself on these types of images of the knee to determine whether you're looking at the lateral or medial aspect of the knee. That's really going to be the surefire way of doing so. So going through the structures on this AP view, we can see the patella and the femur, the medial and lateral epicondyles, along with the medial and lateral condyles. So again, this is going to be medial over here, this is going to be lateral over here. The tibial plateau, intercondylar eminence, which remember the ACL is going to attach to the intercondylar eminence, the anterior aspect of it, and then we can also see the head of the fibula. This is another AP view with a number of these different structures pointed out for you on this specific image. And this is from a older child, and so you can appreciate the epiphyseal lines along the femur, tibia, and fibula. And so this gives you the approximate age at which these epiphyseal plates begin to fuse. So you can see the tibia is usually one of the first of the three to start fusing, so that's about 16 to 18 years old. So I would guess this is probably about a 16-year-old patient that you're looking at. You can see 17 to 19 years is usually when the epiphyseal line of the fibula, or the proximal fibula begins to close or ossify. and then finally the on the femur you can see that's about 17 to 19. That's usually going to be following suit with the head of the fibula. So looking at this image, you can see on top an AP view of the knee, and then down here you can see a lateral view. So this is going to be lateral, this is going to be medial, and note that you can see on all three of these bones the epiphyseal plate, so you know that this is got to be coming from a pediatric patient. So again, these are normal epiphyses in this pediatric patient. Here we have a common condition that affects the tibia in this case, but before we go into that condition and talk about what exactly the pathologic condition that you're looking at here is, I just wanted to go through and review some of the parts of the long bones that we mentioned these in the previous lecture, but remember you have the diaphysis, which as you get towards the distal end, proximal to the growth plate or the epiphyseal plate, you're going to see the metaphysis. Then we have the epiphysis, which is shown here in red now, the sesamoid bone, which is the patella, and then you can see down here an apophysis. And so note the abnormality here and the apophysis. And so this is specifically the tibial tuberosity. And in this individual, which is as common in especially middle school aged children, this is an example of what's called tibial apophysitis, also known as Osgood-Schlatter disease. So this is often happens, especially with excessive running, so playing a lot of sports. It's not uncommon for kids to have this tibial apophysis gets avulsed. So it's basically an avulsion fracture that occurs. And again, we call that Osgood-Schlatter disease. So here we can see an artist rendering of what this tibial apophysitis looks like, or Osgood-Schlatter. And so again, this is where you have that avulsion of the tibial tuberosity, and so that's due to overactivity of the quadriceps tendon. So you can see the quadriceps tendon coming down with the patella embedded within it, and then attaching finally to the tibial tuberosity. And so with overuse of that muscle, eventually you're going to get this tibial apophyseal avulsion. Here we have another image, which is of course a lateral view of the knee. So you can see the patella, the femoral condyles, tibial condyles, and then the head of the fibula with the shaft of the fibula down here. And so there is an abnormality, but it's somewhat difficult to appreciate on this view. And then you'll also notice that there's this other normal variant located back here, just posterior to the femoral condyle. And so that's what's known as a fibella. And the fibella is similar to the patella, but in that case, it's a sesamoid bone, and it's typically found in the lateral head of the gastrocnemius, and it's usually found in about 10 to 30% of the population. So it's not super infrequent, but it's totally normal for somebody to have a fibella. So you want to be aware of that when you're looking at an X-ray of the knee or radiograph of the knee. That if you see this osteoid-like density in the posterior aspect of the just posterior to the femoral condyle, you know that you're looking at a fibella. Here we have another normal variant, which you'll notice that this patella has this what looks like an abnormality to it, and so you might want to, in this case, have a radiograph of the contralateral knee in order to help with differentiating what this may be. But in this case, it's what's known as a bipartite patella, and so this represents effectively an accessory ossification center that's located in the superior lateral pole of the patella, and so that's basically another growth plate or effectively an epiphyseal plate located there in that superior lateral corner of the patella. This is another AP view of the knee. So again, you can see the medial aspect of the knee here, lateral aspect of the knee over here. So you can see the head of the fibula, shaft of the fibula, the intercondylar eminence, and then of course the tibial and femoral condyles. And in this one, you can see here with the patella, you can see something kind of this hypodensity coming across the midpoint of it, which should raise a suspicion that something might be wrong with that patella. And so now, sure enough, when you look at a lateral view, you can observe a very obvious comminuted fracture of the patella. And usually this is going to require an open reduction and internal fixation procedure to fix this extensive fracture. So you can see two pins that have been inserted through the patella along with wire to help reinforce it. And then you can see these are all staples that are used to close the knee post-operatively or at the end of the surgery. Here we have another lateral view of the knee. And if you look closely on this view, this is from the same patient, you'll notice with the patella there's this central defect in the patella. And so sure enough, looking at what's known as the sunrise view, so this is what we call a vertical fracture of the patella, going right down the sort of the midpoint of the fracture, or of the patella, basically breaking the patella in half left to right. And so in this image, what was done was the knee was flexed, and then the image was taken from above the knee in order to be able to easily appreciate the patella without having to look through another bone to do so. And so this is another great example of the saying that one view is no view in radiology. Now we're going to look at some MRI scans of the knee. So you can see the upper two images here represent coronal views. The lower two images here represent sagittal views. So you can see obviously the femurs here along with the joint cavity on either side, and then the tibia located down here. So this is going to be lateral and medial. And looking at some of the soft tissue, which again is what MRI really excels at, you can see the medial and lateral menisci. So they should be represented by hypointensities, so these dark regions of the around the lateral aspect of the joint cavity. And if there's a tear in either of those menisci, you'd expect to see a hyperintensity related to the swelling that will occur with a tear. And so looking at the image over here, you can also, in addition to appreciating the lateral and medial menisci, you can appreciate the anterior cruciate and the posterior cruciate ligaments. The white here, the hyperintensity that you see on both sides, those are just fat pads that are located within the joint capsule here. And then out laterally, you can appreciate the medial collateral ligament in this coronal view. Coming down to the lower left-hand image, and this one, you get a really nice view of the posterior cruciate ligament, which we'll talk about a little bit further here in a moment. So again, that's the PCL. And then you can appreciate here a really nice view also of the articular cartilage of the knee. You can see that on both sides here. This is the articular cartilage of the knee. In this case, of the femur. You can also see on this one the fibula, and then you can see two horns of the lateral meniscus in this case. So note that you can see the fibula, so you know you're relatively lateral in this view. And so at this point, you can see both the anterior and posterior horns of the lateral meniscus. And so when looking at a sagittal view like this, you want to be looking for a tear of either one of those horns of the lateral meniscus, because usually the tear will affect one or the other, but not both. Okay, now looking at another sagittal view where you can appreciate the ACL. So again, you can see where it's running from the lateral femoral condyle above to the intercondylar eminence down here below on the tibia. And remember that this is going to prevent anterior translation of the tibia on the femur. So remember that the anterior drawer test then is going to be a good way to evaluate the integrity of the ACL. So what you do with that test is you're going to you immobilize the femur and then pull the lower leg or the leg forward so that the femur will translate along or move anteriorly along the surface of the femur. And if the knee is capable of doing that, that indicates a high likelihood of an ACL tear. So it should not normally have much motion when you pull on the leg with the femur immobilized. Again, assuming the ACL is intact. All right, here we have an artist rendering of a sagittal view of the knee. So again, you can appreciate the quadriceps tendon with the patella embedded within it. You can see where it's attaching to the tibial tuberosity down here. You can see the articular cartilage on both the femur and on the tibia. And then you can see where the ACL is attaching to the intercondylar eminence of the tibia, and then the part of the femoral condyle posteriorly here on the femur. So again, you can see where then trying to pull the tibia forward on the surface of the tibia, this ligament's going to resist that movement. This is a MRI from a 12-year-old boy who experienced a trauma to the lateral knee. He actually had a fracture of the tibial plateau, but he also had evidence of an ACL tear. So you'll note in this image that there's all this white swelling in and around the ACL, and so that indicates a tear in the ACL. This is a really beautiful view of a PCL, so the posterior cruciate ligament. So you can see it coming down and around here. So that's going to run from the posterior intercondylar fossa of the tibia to the inner surface of the medial femoral condyle. And remember that that's going to be performing the opposite action of the ACL, and so it's going to be helping to prevent posterior translation of the tibia on the femur. And on MRI, it should always appear uniformly hypointense. So you'll note how the entirety of it appears black in this image. Whereas if you look in this image, you'll note that there is here's the PCL. You'll note that it's not uniformly black along or hypointense along its entire course. Instead, you have this hyperintensity located right here, and so that indicates a tear in the PCL. Now looking at an artist rendering of the menisci, so we can see the medial meniscus has more of an open C shape, whereas the lateral meniscus has more of a closed C shape. So it's more circular, whereas the medial meniscus is more of an open kind of half circle. And then you can see how the menisci are attached to the tibia via the coronary ligaments. So there's a number of different coronary ligaments. You can also see the cut surface of the PCL and ACL in this image, as well as one of the menisco ligaments, in this case known as the transverse ligament of the knee, that's attaching the medial and lateral menisci to each other. Here's some additional coronary ligaments. There's going to be some fibers coming down off of the medial meniscus here and helping to anchor it to the tibia as well. And then finally, you can see the medial and lateral collateral ligaments in this image as well. All right, so looking at evaluating the medial and lateral menisci on MRI, so here we can see these structures right here represent kind of the light gray that you see. Those are the articular cartilages of the femur and of the tibia. And then just lateral and medial to those, you should be able to appreciate the medial and lateral menisci. So they are going to be these dark hypointensities that you see on either side there, kind of like what we saw with the PCL. Oh, and one other point, sorry, with the medial meniscus is you'll note that that's going to be closely or firmly attached to the medial collateral ligament, so the MCL, and so that puts the medial meniscus at greater risk of tear as a result. So if a patient has a tear of the medial collateral ligament, there's a good chance the medial meniscus is also going to be affected by that. So looking at the structures here, you can see the popliteus tendon, as well as the lateral meniscus, Gerdy's tubercle there on the femur, on the tibia. That's actually commonly used as a bone graft site. You can see the medial meniscus over here. And then you'll note in this image here from Complete Anatomy, you can see the popliteus muscle, lateral meniscus, Gerdy's tubercle, medial meniscus. And then here we have the articular, you can see the articular cartilage coming around here on the femur as well as on the tibia, and then you can see the menisci here. And so note that the anterior horn of the medial meniscus in this case looks hypointense, looks normal, whereas back here you'll note that there's this sort of hyperintensity right in the middle of the medial meniscus and the posterior horn of it, and so that indicates a tear of the medial meniscus. Here we have another AP view of the knee joint, and so looking at this, you should note that this is from a pediatric patient because you can see clear evidence of the epiphyseal plates. And from the same patient here, you see on MRI with this coronal view, you can see a very evident tibial plateau fracture. But if you go back to this one, you don't really see any obvious evidence of a tibial plateau fracture. So this shows you just an example of where an MRI can really be useful for identifying a fracture in a patient.